Hello, everybody. I'm Bob Dempsey, and we're going to be talking about COVID. And this is probably one of the more important meetings because we're going to be talking seriously about vaccines. The message for today is keep your eye on the prize. Don't get fatigued near the end. If you've ever climbed mountains, you'll understand that most of the accidents occur when you think you've got it licked, when you think you've got everything under control, not when you're striving on the way up. And therefore, if we are getting toward a solution in a time of a crisis, this is no time to slack off. This is no time to forget the rules of protection. But for the first time, we've got some light at the end of the tunnel against a very difficult and dangerous disease, in spite of the fact that some people have grossly underestimated its importance. So we're going to talk about keep your eye on the prize. We're going to talk about why we're got some hope. I had made the crazy prediction back in April at one of these talks that we might have a vaccine by the end of the year. That was nuts. The world's record was 4 years to develop a vaccine, the mumps vaccine. It's never been this fast, but I thought enough scientists working together might pull it off. Well, they have. Now we have to make sure it works. We roll it out. Who gets it? When do they get it? Is it safe? Lots of questions remain, but let's see where we are. We are in the midst of a big surge of a very dangerous infection. It's very, very infectious. It's easy to get it. And if only 2% or something gets severely ill and die, it's a massive numbers. Like worldwide, 63 million people we know have been infected. Obviously far more because most of the world doesn't test. 1.5 million deaths. The United States, a very disproportionate high number, 13 million. 260,000 dead. Think about that. Wisconsin, 400,000 sick, 28,000 in Dane County. Just think about the election we just had. 20,000 people would have swung the entire state. We have that many sick in Dane County. The number of deaths in the United States would have swung the election. So it tells you if you underestimate this, you probably don't deserve to get voted for. Okay, now stay with it through the vaccine. We are in a dangerous time. Many of you may know we had a 16-year-old die. That's the youngest in the state, a student at East High. And this is COVID. This is possible. We have 89 people in our hospital with COVID right now. Those are 89 beds that we can't use for neurosurgery that we are triaging brain tumors. We are overrun with strokes, which is related to COVID, and we are working at an increased rate with a smaller hospital to put them in. It's quite stressful. We're doing a very good job, but this is an ongoing concern. And we are probably 3 beds away from running out of ICU beds. We're going to have to find others. We're going to have to restrict others. Now, important why we cannot let our guard down, why we must mask, shields, wash hands, distance, is that there have been 2,900 healthcare workers in the state of Wisconsin infected thus far. I mean, and these are the people that are trying to follow the rules. You can see the amount of risk that the rest of the population is put under. I still estimate that if you go into the grocery store, every 20 to 30th person you met is infected, is infectious, and doesn't know it. So you must distance. This is why we're so worried about what's going to happen as the Thanksgiving travelers and the Thanksgiving gatherers of extended family become sick. Will our numbers surge and will we overwhelm things? Because this message I'm going to talk about vaccinations and what their benefit is aren't going to be realized till mid next year, the benefit that is. And so we must stay the course. We must not let down our guard. We must not be the mountain climber that falls because they thought they had it made near the end. So let's talk about vaccinations and what we need to survive the holiday surges to get to. There are 36 vaccinations in development. There are many types. I'm going to try to cut through that so it makes some sense. But it all goes back to Jenner and smallpox when he understood that those milkmaids that got cowpox, a similar but not very virulent disease, were protected from smallpox. So he gave them milkpox to people. They got a mild illness and they were free of smallpox. What happened, of course, was your immune system sees something new, different, or threatening, like a virus, or a cancer cell, or a bacteria, and it mobilizes its immune system in 3 steps. It grabs this offending antigen, something foreign, could be the cell or something on it, protein. It presents it to its immune system. It causes you to make antibodies, which will help to recognize it in the future, and killer cells and cells that make antibodies. That revved up immune system then stands ready if you ever get an infection again. So those nursemaids, I should say, that got cowpox had this revved up immune system, and when smallpox came, their immune system wiped it out. Okay, that's what we're trying to do, because a virus will spread whenever it finds willing hosts. If it kills everybody, it can't spread. If it kills 2%, it can spread. And if it were to infect 80% or more of society, roughly that number, it's not going to have a lot of luck finding those other 20%. That's what herd immunity is. Well, you can't get herd immunity from coronavirus without killing 8 million people in America. So that's crazy. But you could get herd immunity in a way by just not allowing the virus to see other hosts. That's what isolation, masking, wash your hands is. Well, we've shown very clearly that as a society, we're not willing to do that. And that's sad. It's very sad. People have been misled. We have to model the proper behavior. But we could also obtain that herd immunity by vaccinating enough people that the virus cannot find willing hosts. This is going to be important because if people don't believe this is a real disease, they won't take the vaccination. And if only half the population gets vaccinated, well, we might have some very dire events in the other half. It's hard to say, but that's possible. So we have to have people have faith in the vaccinations, and they have to work safely. Let's think about what that is. Well, as you move past Jenner, who 200 years ago came up with this idea, you have people trying to make vaccines to, say, a particular virus. And there are many ways to do that. The oldest and most traditional was you grow a lot of that virus, say in eggs, and then you inactivate or kill that virus. Then you inject it into somebody, and you hope their immune system will be riled up by the dead virus, cause a reaction which will remember it when it sees the live virus later in an infection. You can see that this has its pros and cons. It works sometimes, it doesn't work. It's fairly cheap because we've been doing this for decades, but it's slow. And therefore, the people working on those techniques are kind of behind. Yet it's cheap, so if it works, it's something we may roll out worldwide, because not every country is as rich as the United States and will throw trillions of dollars at this problem as we have. That's why we have 36 different virus vaccines in production. We don't know which one was going to work, so we said we'll fund them all. All right, that oldest type is what's coming out of China, and that's the one that they claim will be effective. They haven't proven it yet. And you can see where it might not be effective. Maybe your immune system just finds this virus as too dead to get excited about. Or they will inactivate it so it doesn't make you as sick. The safety issues are real there as to is it really inactivated? But that is a common type. Another type, which is one we call the AstraZeneca, is where you take a virus that doesn't make you very sick, such as an adenovirus of a certain type, such as a chimpanzee virus, makes chimps sick, humans not so much. And you attach an antigen from the coronavirus to it so that when you give it to a human, they don't get very sick because it's a chimp virus, but the immune system recognizes that little bit of coronavirus that you put on it. And when it sees coronavirus, it's been supercharged to fight that. That's what AstraZeneca is working on. They are behind because it's harder. They have to make viruses. It takes more time. But there are many derivations of this, and they've been used in other things like shingles, etc. And they've been able to be done and safely. We have a lot of experience, but that's slower work. However, just the nature of the AstraZeneca vaccine is that it's relatively stable. And if it does work, they'll be able to make it cheaply, older techniques, and store it less cold, just refrigerate it. So it is ideal, if it works, for the entire world, because we have to inoculate people in the Congo. We have to inoculate people in the Yukon. We have to, many different areas and many different areas of wealth. The real ones that are out in front right now used an entirely new method where they basically gave you a piece of the RNA of the virus and told your cells, make some protein, which is odd. That is the spike protein on the outside. And so your immune system is revved up to that spike protein. And the thought is that even if the virus mutates, and viruses do mutate, it's not going to mutate the spike protein because without that it can't work and attach, it would die out. And that may be sound because you can't get sick from you can't get coronavirus from the spike protein alone. So the two viruses, the Pfizer and the Moderna, have used similar techniques, but they took that little microRNA and they wrapped it in a glycoprotein. That's what they inject into you. It's not even a virus, it's just a protein. But that glycoprotein is unstable and has to be stored very, very cold. So it's hard to transport. It's not going to get to the Congo. But we have those freezers here at UW, so we could do it. And it's very much faster because you don't have to grow a lot of virus, but it's very expensive. So that's the sort of thing that you see in the United States. Expensive and fast. Now, it's been tested, both of them. They were very effective, like 95%. If you got the vaccination, 2 doses, and went out and lived your life, and then your let's say, a number of you got vaccinated and a number of you didn't, there would be about, 95%, so it'd be 20 times more infections in the non-vaccinated people. And interestingly enough, those that got vaccinated and did get coronavirus didn't get very sick. So it's probably protective even against a high viral load, at least protective. So what we know is it's efficacious, and in that smaller 30,000 people, it seemed to be fairly safe. There's reasons to believe it would be safe. But we are going to go ahead, I predict, and roll this out before we've done the huge safety trials, which can take years. And that's because of the pressure of this particular pandemic and the desire to end it. And I agree with that, even though there's a risk. So the important things are these two that are out in front, because they're easier to make, even though more expensive, have to be stored very cold. -80 for one, -4 for the other. What's going to happen is next week, the United States regulatory agencies are going to review them, and I predict they will approve them, the first two. I predict that they've already been making it on the hopes that they would be the ones to be approved. In other words, there are hundreds of thousands of doses possible, and they're already being made on the chance this would be the right one. So that's the way we've been doing it. Enormous cost. The ones that don't work, we already made lots of it. We'll have to throw that out. These seem to work. So I predict that a week later, third week of December, Wisconsin will get 100,000 doses. Now, who gets it? When? Who? What? Well, it's going to be determined soon, but this is what I predict because I can see the way they're evaluating. The first people to get it are going to be frontline medical workers, doctors, nurses, respiratory therapists, etc., with direct patient contact of COVID patients. Okay? That would be, the nurses in our ICU that has only COVID patients. And that makes sense. The second group will be the people that have some COVID contact. Most all of the nurse surgeons, the residents, the nurses on nurse surgery fall in that category. Farther down will be people that have contact with patients, but they're usually healthy patients. They're the same as society. And then farther down will be, I predict, it'll be people that do not have contact with patients or COVID patients. And I do predict very quickly after healthcare workers will become nursing home residents, prison residents, packing house workers, people that we've shown to have high infection rates and high risk occupations. As this is rolled out, it's going to take months to make it, to develop it, to deliver it, and to check its safety. So in essence, the real safety tests, the real big ones, are going to be done by seeing how the healthcare workers do. And that's what's going to happen. And I think we should. And I endorse this. We should do this. But that's where we're going to find out if by the time we have enough infrastructure to inoculate everybody, including the people who have been isolating, we're going to be well into the spring and we'll have a better idea about its safety. So let's think about that. What I'm saying is that if there are 100,000 doses coming to Wisconsin, I'm going to bet that the University of Wisconsin hospitals will get about 5,000 to 10,000 doses in the third week of December. Well, we have 13,000 healthcare workers with patient contact. So that's why we're, at least for that first wave, it's going to be triaged to the people putting themselves at greatest risk, and then down the line. I suspect that those intermediate people may be inoculated in January. That's assuming we have a steady supply stream. There are people who have been planning this for a long time. Within our own buildings, we're going to be inoculating people in two major sites, in the hospital and a huge warehouse that we built, which I think is near the airport, where people can actually drive through and be inoculated in their cars. Again, we're trying to protect the people giving the shots and to isolate people. So this is a big enough building where we can watch people in their cars to make sure they have no immediate abnormal reaction to the inoculations. It's going to be difficult, but that's what we're going to have to do. So what's the logic? What's the benefits of having more than one type of vaccine? Well, one, if we can get 2, 3, 4 that work, they're each been making 100,000 or 1,000,000 doses, we'll be able to inoculate lots of people. We, at least initially, do not have a choice. We're going to offer, this is the one we got. Do you want it? You can say no. And if you say no, fine, they'll go on and give it to the next person in that hierarchy of risk. If down the line, a month later, you say, gee, I changed my mind, I really want it, they'll put you back in the list at the priority you were, your direct patient contact. No one's going to be forced to get a shot. However, I recommend it. The benefit of doing this is that not all the safety tests have been done. Not all the efficacy tests have been done. We can get some people, the highest risk people, inoculated with the first ones we've checked. The second is the virus can't run and hide. If it were to mutate or change, and we have multiple different antigen targets in multiple different vaccines, we have a better chance of catching it, wiping it out. And interestingly enough, this is only one virus, and it needs its spike proteins. So that's its Achilles heel. Unlike flu, where there's lots of viruses and you give a vaccine to one and it's the wrong one that year and another one pops up, or common cold. This is one virus, and like smallpox, we might be able to catch it. So it's worth it. And certain vaccines travel better. They don't have to be as chilled as much, or they're cheaper, or we can make more of it faster. That's the advantages. So I predict there's going to be a lot happening next week. There'll be a lot of news. And the very first nurses and doctors working in the all COVID ICU will be inoculated the week after as we work through how we do this. I think that, it's very important because it'll take us a while to get through 13,000 healthcare workers. And then, we need to rather quickly pivot to who's at greatest risk. And it's going to be our nursing homes. There's many issues. We haven't tested this in children. And we're not quite sure what we do there. We need to make sure, because their risk of catching it is lower than, say, a nursing home person. We have tested in elderly, and it seems to work. Not only does it make antibodies, that's our goal, but these seem to be protected in the first trials of, say, 30,000 people, which is a small number. But within the month of December, we're going to have numbers in the hundreds of thousands and follow how is everybody doing. So there is a lot going on. It is important and it's good and it's hopeful. There's things we have to do. We have to stay the course well through the middle of next year. Mask, separate, wash your hands, isolate it. There's not going to be a holiday party this year, but what meager funds we have for that holiday party, we're going to roll into next year for our post-COVID-19 celebration. I don't know when we're having it, but we're all getting together and we're going to celebrate. I'm hoping for that to be in the late spring or summer. So this is no time to lose your eye on the prize or to fall off the mountain because you got sloppy because you're tired, or to start visiting all your family, much as I want to for the holidays. Stay the course, model the correct behavior. We need our society to get past these political wranglings and do what's right for each other. And I have high hopes for this coming year for that, if we model that. So this is the real thing we've been hoping for, an effective vaccine. We just have to make sure that we arrive healthy to that point. Again, I can't thank you enough for all that you do. Let's keep our chins up and a healthy attitude, and a happy holiday season to everybody.